Hi everybody, and welcome to our Instagram Live tonight, Fertility Q&A session. I'm really happy to be back. We are here with Dr. Kenneth Gelman. He'll be joining us tonight. And I really hope that we can have a chance to get all of your questions answered. So if you haven't submitted them already, you can actually type them into the chat tonight. And you can also message us or direct message us, however you'd like to do it. I'm going to go ahead and invite Dr. Gelman on right now and see if he can hear me. He can request to be in, actually in our live session, it'll be under, I'm looking for the IVF MD account. So anyway, hopefully he'll be joining us soon with that, under that account. And I will be inviting him in. So we have actually a few questions that were submitted ahead of time, and those will definitely be answered tonight. I think it's important to look at, the differences with natural treatment, IVF, IUI, how to prepare for whatever route of treatment you're doing. So we're going to talk about natural strategies and also talk a little bit about hormone testing as well. If you have also time to do cortisol testing, you can actually do that as well at home sometimes during a pandemic when you're working from home or you're actually having more time to spend at home. There are some interesting, newer tests that are out there that could be helpful for you as well. So I'll go ahead and invite Dr. Gelman. I see him here, so I will go ahead and invite him on. Let's see here. So we will get him on in a moment. So I hope everybody's healthy and doing well. I'm really...
There we are.
Oh, there you are. Yeah.
There
How are you? There you
How
are.
are you?
Good. Welcome, Dr. Gelman. I'm glad to have you join us tonight. And thank you for being here. We have some questions already that were sent in, but please, guys, feel free to join the chat. Type your questions in the chat and we'll get to them tonight. Anything and everything about fertility, PCOS, endometriosis, preparing for an IVF, early pregnancy during COVID, anything that you'd like to ask us, please feel free. Dr. Gelman, can you introduce yourself to everyone who doesn't know you?
Yeah, I'm Dr. Kenneth Gelman. I'm part of one of the 12 physicians of IVF MD, and we're in the Broward office in Cooper City, specifically with Dr. Ellen Wood, and Dr. Sabrina Gerkowitz is in there, so our newest member. So, we've been there in Broward in that particular office since 2015. Before that, actually, I was part of IVF MD, but in a separate office. But now we're all joining together in that office there, and it's a very busy place. And we welcome your questions, and we welcome any one of you as new patients or prospective patients.
And I also wanted to give a chance to, for the people that were looking for the IVFMD login. I don't know if you're able to switch logins to the IVFMD one, Dr. Gelman, or are you joining?
I'm sorry?
It looks like you're joining from your personal account, so I didn't know if you want to go back in with the IVFMD account or...
Jesus, I was on the IVFMD account before.
Okay, well, it's fine. Hopefully everybody will find us here, and
okay.
We'll also post this. We'll share this with IVFMD tomorrow. So,
okay.
So we have a few questions. We'll go ahead and dive into those. And the first one is that we actually had submitted to our page was during the medication period for IVF, are there specific recommended foods to eat and to avoid for both men and women? If doing for men, if doing a fresh sample. And for women, do you guys have anything that you recommend as far as like with Marta or anything like specifically for what to eat and what not to eat to your patients?
Well, I mean, if you speak to Marta, our nutritional counselor, I mean, if you talk to them, they're going to have specific diets that a lot of the patients end up seeing our lifestyles consultants before they even start, just with that specific idea in mind of getting healthy and achieving, some of the people have to achieve a better, BMI, for example, and we would have them see our lifestyles consultants to help in that, and they do a great job. And, they're very I would say, healthy diet. I mean, obviously, like any doctor would advise any patient, like a cardiologist advising a cardiac patient, we would advise the patients we see the same way, because, we always talk to them about, what could potentially affect your eggs. And when you look at data, I mean, there's data now about inflammation and things like that, affecting egg quality. Not only, reproductive toxins, let's not even, let's mention that, but, I'm not going to specifically say that, but the foods we eat, seriously cause inflammation in our blood vessels. Well, our blood vessels feed every organ of our body, including ovaries and testicles and, things like that. So theoretically, the healthier you eat, the better quality of your sex cells. So I always recommend Mediterranean diets to people.
Yes, we love the Mediterranean diet.
I think those are the healthiest things you can eat, and most people can follow that. I mean, it's not something so far out that you're not gonna. It's not so unpalatable. Some of these, you don't want to recommend things that people are definitely not going to follow. Yeah. So eating with sense, I think, is right. Important. A lot of fish, a lot of antioxidants,
healthy fats,
berries, healthy fats, avocado, and that's why the lifestyles consultants are so important, because they can really design diets for people more specifically, with what they like, and tailor it more to what they eat and things like that, and follow them, and also give you objective data. That these patients are doing well. They follow lab work, they follow cholesterols, they follow HSCRPs, they follow all these things, BMIs, all these things to help us improve the patient as much as we can. I mean, and that's what we try to do, as best as we can for most people. Everybody's anxious to get into IVF and get pregnant, and we're anxious too. We want to see people pregnant. We want people to be happy. But there's times when we would say, listen, you're not optimally, ready to go through this process. It's a very expensive process. You're going to be spending a lot of, not only hard-earned money, but emotion and time on something that's not 100% at best. So why not try to make it as close to what the real success rates might be for your age, rather than struggle or, have to go back to the drawing board again, maybe because you weren't quite optimized.
Right. So I think fad diet sometimes can set you back. And we've talked about this with Dr. Wood on our Q&A sometimes, where you could, not be optimizing your health as far as getting ready for pregnancy. Definitely during pregnancy, we're not recommending dieting or fad diets and that sort of thing. So some of the foods, I think that during pregnancy that are not recommended, sometimes people think they're not recommended when you're trying to conceive, but that's not necessarily the case. Like raw sushi and cold cuts and all those things, they're not recommended for different reasons during early pregnancy. And right. Chinese medicine, we try to stay away from too much of one thing, perhaps like too much cold stuff, too much raw things, that sort of thing, as well, just for your digestion in general and circulation. But I think that you have to take into account, but when you're eating something, you're basically eating for your brain health and for your anti-inflammatory health as well. So the Mediterranean diet is something that we recommend for at least 6 weeks for most of our patients, like a gluten-free Mediterranean diet can be followed pretty easily. And after that, we definitely say if there's a weight loss goal that you need to achieve, to definitely seek help with that. Or if there's also, difficulty in meal prep and those sort of things. Now that everyone's at home a lot, everyone's cooking more and getting into, meal prep and that sort of thing as well, involuntarily. But I think that's kind of on the bright side of things, right?
Yeah. I mean, it looks like some of those delivery companies, I guess something fresh, I can't remember the name. They look like they have fairly healthy things. I mean, if the foods are truly fresh, looks like I looked at one of their meal plans that actually looked fairly decent.
Yeah.
So for people who don't cook, I mean, it's hard
Mhm.
to cook after you come home from a day's work, or that kind of thing. You want to go out maybe to exercise for an hour, and you got to sit down and cook. It's hard to do that.
Yeah.
So some of these things might be fairly advisable to look at. But I think diet is really important. It really is. Plus, you feel better.
Right. So for sure. Hope that that answered the question there. And I'd say for both men and women to, the men,
Both, absolutely both.
because
And a lot of times, you're right, because specifically in regards to men, a lot of times, the men get neglected. They really do. Most of the visits, 80% of the visits are women. Men come along, a lot of them reluctantly, because they're forced to or they have to. But the ones that really are interested, we definitely meet with them, and I make it a point to try to meet with men, because a lot of men sometimes don't like to meet with the wife there, and I always encourage the men to come in separately,
yes.
So we can discuss things like whatever they want to talk about, man to man kind of thing, and they like that, and we get into diet and things like that because that's important. Obviously as a physician we're interested in overall health, but I think just in terms of feeling better and achieving better BMIs for some of these guys, and maybe some of them have a lot of them maybe have low testosterone and high estrogen levels, which are related to being overweight.
Mm-hmm.
So, it's very important that the men get counsel too, because, it's neglected a lot in this field.
Yeah. Yeah. And there was a research study, I think it was done in Greece, where they actually looked at couples in their 30s, and they looked at what type of diet they were following. The ones that followed closer to the Mediterranean diet had a huge increase. I mean, it was like 30% more take-home baby rates, and the sperm quality was better too.
Much
So
better.
why not? At
Yes.
least that's what we implementing that and saying, it's never going to be a bad thing to have too many healthy sperm. So
no, it's not. It absolutely isn't. And that means good health. I mean, it definitely means good health. When you have healthy sperm, it means your body's healthy.
So that's great. And then Marta's excellent too. If anybody or you guys have nutrition that can help as well. I know things like high insulin and high glucose and all those things can really interfere also with fertility and health in general. So it's really great you guys incorporate the lifestyle component. I don't know.
No, it's a must. I mean, I think it's so important. I think again, that part, I think maybe a lot of other practices is not really focused on at all. Yeah. I think that's what makes us unique in that sense, because we do focus a lot on that. And, we definitely counsel all our patients, every one of us. And again, the lifestyles consultants are just invaluable in our practice, what they do.
Oh, I really want to thank you guys for that. I think that's a big part of it. Of our patients being so healthy too, which is awesome.
Of course.
So as far as we have another question about it just basically says ovarian endometriosis and pregnancy success rates.
Ovarian endometriosis?
That's what the question says. Yeah.
Mm-hmm. Well, it depends. I mean, endometriosis in the ovaries, we do see that obviously fairly commonly. But again, the success rates of that itself, really will depend upon the degree of endometriosis really in general. I mean, for example, I see patients with endometriosis in the ovaries, totally asymptomatic. They never knew they had anything. And yet, they go through IVF and they do fine, but, they're going to usually need IVF for that because of the fact that endometriosis is an inflammatory disorder, like we were discussing in some sense. But basically the premise is taking the eggs out of there, getting the eggs out of the inflammatory environment is going to help you get pregnant. And that's why the IVF is done. But, when we do the IVF, we work around the endometriomas. Nobody goes in anymore these days and takes out endometriomas, or shouldn't. with rare reason to do anything like that, because it's going to disrupt the ovary and decrease the ovarian reserve even more and affect the prognosis. So people with ovarian endometriosis, usually have endometriosis in their pelvis also. You can be symptomatic or asymptomatic, but you're still likely going to go through IVF to get pregnant, most likely.
Okay. Well,
and the success rates are good. They're lower than what would be for your age, because of the endometriosis is going to decrease your success rate. So if you're older, I think you should, try to get this done as soon as possible, because your success rates might be decreased a good 10 to 15%.
Yeah, and I mean, endometriosis also is inflammation as well. And I think back to addressing also the inflammation is very important. So that can be done with omega-3s, a healthy diet, working on circulation. That's what acupuncture does well. And we do work with the period. I mean, we try to work with that beforehand, as far as if there are clots, pain. Clots to us signify poor circulation, poor microcirculation, which might not be as favorable for implantation as well. So we try to work, if we can, a few months on that, or a month or two prior to the IVF cycle, so that we can have time to improve a little bit of that circulation. By the time you get to IVF, hopefully it's going to be more successful. So that's kind of what we focus on. And I think, with your part, hopefully, does that affect, do you feel like maybe they're talking about endometriomas? That's
what we were discussing, that kind of thing. Yeah, it's gonna potentially affect egg quality, but again, depending how extensive they are, how big they are, what the age of the patient is. I mean, obviously, if the patient's 40, there's going to be decreased success rates based on that, in addition to the endometriosis. So I mean, it has to be looked at sort of in a total picture in terms of what we're really dealing with. But endometriosis is we work around the endometriomas. Essentially, we would stimulate that patient and try to get the eggs around those endometriomas to grow and take them out, and then hope and pray you've got reasonably good egg quality and good fertilization, obviously.
So surgery is not always
not for that. I mean, that was always the debate, and maybe if the patient has gone to a non-specialist, some of them may end up with surgery by the time they get to us, and then they have a very low ovarian reserve, or they don't have basically very poor egg quality, poor ovarian reserve. They won't even stimulate because so much, maybe a large chunk of the ovaries was removed, and that's going to affect the process.
So definitely a lot we can talk about. The endometriosis is almost a whole separate Q&A session, but feel free. Hopefully that helped, and feel free to DM us if you need any more details about that. We have a question about intralipid. So how do intralipid infusions work exactly in preventing miscarriage and high natural killer cell antibodies?
Well, intralipids are, somehow there was experiments years ago. They discovered that intralipids were almost as effective as IVIG in suppressing killer cell activity. The mechanism is not really clear to me how it works, but the nice thing about it is that it is there's no side effects. And in situations where we think intralipids is adequate, it really does seem to help. There's debates about how much to give and when to give it, but it certainly seems in certain cases as effective as IVIG. There are special tests that you can do that look at your natural killer cell activity. And during that, when you get that test result back, it looks at how much suppression you get of your natural killer cell activity with intralipids versus IVIG. So whether you're getting suppression with intralipids versus IVIG, and you could probably use those. I mean, there are certain circumstances where you can't use IVIG, or you shouldn't use IVIG, and particularly patients who are very autoimmune. where they may have obviously a history of recurrent pregnancy loss, where they have elevated natural killer cell activity, as well as an elevated phospholipid antibody panel. Where they have those two things, and especially if they have thyroid antibodies also, those patients are pretty autoimmune. Those patients probably should get IVIG, which is stronger and sort of interferes with the immune function of those cells. Now, there's always a debate about, whether your natural killer cells are high in your blood, whether that has anything to do with your miscarriages or not. Mm-hmm. That's the big debate, and a lot of people don't think has anything to do with it because it's a non-specific blood natural killer cell. And then there's a test that we do called the endometrial immune panel, EIP, which looks at actually killer cell function, or the chemicals they make inside the endometrium during a frozen embryo transfer prep. So it kind of gives you an idea, really, when you're prepping for a frozen embryo transfer. And that's why frozen embryo transfers are so good, because you can you can prognosticate these things.
Oh, neat. Okay.
You can find out if there's any little autoimmune problem going on in the lining itself, which is where the action is.
Oh, nice. Okay. And that is pretty much done routinely, like with the blood work, whenever they're getting the workup for the immune panel? Or
I'm sorry?
So you're testing the endometrium for natural killer cells as well, or that's
it's the byproducts of them, like certain cytokines they're called.
Okay, very neat. So then, as far as how it works, I don't know if I've kind of been looking at that and pondering it myself, but is it kind of like a decoy in a way, like for the immune system to kind of work where, where it kind of suppresses? Does the intralipid actually suppress anything? Because they're asking, how does it work in actually preventing miscarriage and lowering the natural killer cells?
Well, it does. It just interferes with the natural killer cell function. Mm-hmm. So it reduces their activity. So exactly how it does it, I'm not exactly sure how it does it. I mean, the IVIG has a more specific action in terms of intercalating in those antibodies and blocking what their effect is. And the intralipid probably functions similar to that somehow. So I'm not sure exactly how it works, but it does work. It lowers their action or their activity. So actually, you see their activity go down. So what happens is that when you treat somebody with intralipids and and it works, once they're pregnant, you monitor their natural killer cell activity, and you see that it's suppressed or it stays low. So the intralipids are actually lowering their activity. So and it's successful at that point. And then after a certain number of weeks, you may not need the intralipids anymore because there's so much steroids going on in the pregnancy. It suppresses the activity completely, or there's changes in these what's called Th2, Th1. Mm-hmm. There's changes in the immune system so that you don't need any more immune suppression. Very
cool. Well, I know nowadays people are wanting to boost the immune system so much, all those things. So I'd be curious to see if the people that are having these high natural killer cells, what's the incidence of them getting, the virus? That would be cool study to look at.
Well, I mean, who knows what, that's what I'm saying. When you draw, a natural killer cell level on somebody, and they tell you, I had a miscarriage, how do you know that natural killer cell activity is related to that, problem or not? Mm-hmm. I mean, it could be maybe the person is exposed to some kind of virus, has elevated natural killer cell activity. You don't really know.
Yeah, no, it's a lot of.
It's a non-specific test in a sense, or it could be.
We have another question about how often do you recommend acupuncture before starting IVF cycles? And for patients that we see that are doing medicated cycles, we try to, like I mentioned, work with them at least like 6 to 8 weeks prior to starting a medicated cycle if possible. And sometimes we don't get that luxury. We sometimes see them, more closer to stimulation. But I think it's great to help the nervous system to kind of go into switch over from sympathetic to parasympathetic mode. So, you know, that's actually more conducive to help work on cortisol levels. There's been studies actually, and more studies that have been out there with acupuncture lately, and IVF have been actually doing the acupuncture 6 weeks prior to a medicated cycle. So that's kind of where our baseline is. And also, I just think it gives patients a little bit of time to kind of ease into the routine of the acupuncture, and then gearing up for all the appointments and all the little bit of stress that comes with starting an IVF cycle. So to kind of ease into it and not to jump into everything all at once. So, so what are your thoughts on that? What do you tell your patients?
No, I think that's great. I mean, I tell them if they can get there 2 to 3 times a week, that would be ideal. You know, at least 3, you know, if they can. I mean, you know, it's obviously an extra thing they got to do. And, you know, a lot of people, you know, a lot of the more motivated people will do it. And they appreciate it, because it really, really makes a difference. And, you know, I see the patients, they come back and I ask them, how's acupuncture going? They say, I really love it.
Yeah.
Yeah, it really makes a difference in just your overall, you know, sense of relaxation. I mean, it just makes you feel better.
And also
not stress.
Extra time for improving circulation as well in certain patients.
Yeah.
Some patients do, you know, improve faster than others. We can usually judge by also the circulation in the feet and the hands. So sometimes they walk in, they're like, oh, my feet are always freezing cold, you know, and we can look at it and it's like ice blocks, you know, like, okay, it's going to take time. But, and we
that's a good sign of anxiety. And, you know, you're relieving their anxiety by doing that. And, you know, you're doing it, you know, better and more naturally with that process than, you know, taking Zoloft.
Yeah, right. Yeah. And in the whole process, sometimes it's kind of nice to have someone on your in your corner to kind of go, okay, you're going to get through this, and it's going to be over before you know it. And you're, you know, hopefully not going to ever have to do this again. You know, it's not, but in general, even with IUI cycles, I think it's important just to have acupuncture at least once or twice a week. Twice being optimal for any medicated cycle if possible. And then we also work with our patients after the transfer as well.
Well, I was going to say that study, I mean, you've shown me studies and we've seen studies that it reduces the risks of ectopics,
yes.
Which is really important, I think.
Yeah, there's one that actually was done on donor too that was very interesting because that was a smaller study, but it actually showed you know, that it was there were like lower risk of ectopics and miscarriages, which actually is so I think, you know, looking into all the research, we actually have a book that for patients, and I'll be happy to send you guys a PDF of that book if you want to DM me about if you want the book. It's basically written for couples or for anyone who is trying to prepare for a medicated cycle or just naturally. It has all the research that we talk about on acupuncture and how it works, why it works. It's kind of, you know, a mystery to a lot of people. Like they have no idea what it is. So I put that together. It's pretty much just to answer questions from patients over the years. So I'll be happy to send that to you guys if you would like a copy of that. We try to give it to all of our patients, and it's on Amazon as well. But in any respect, if you would like more information, you can also go to our website. It's floridacompletewellness.com, and we actually have videos. We have a whole page of YouTube videos. Some with Dr. Gelman as well, with Dr. Wood, with other practitioners that we interview, and we talk about ways to help prepare yourself for a cycle, and also things you can do with your partner as well. So just it's actually under, I think it's under our it's this first or second. It's on the homepage, I believe, under videos. So that's what our questions were before, and then we also have a question that was just submitted about AMH. So someone is asking, is it recommended for women with a low AMH that start IVF to be placed on birth control?
Yeah, that's a biggie. I try not to do that because, but again, this also depends on the age of the patient, you know, where we think the AMH is accurate. And I mentioned this in previous talks we had. because sometimes patients come in and they're, with a very low AMH, a particularly young patient, and the OBGYN, may have seen them and draw an AMH and an FSH. Their FSH may be fine, or the AMH may come back very, very low for their age, and they scare the patient. The patient may be 30.
Yeah.
And, they're having regular cycles, blah, 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 and they went in for a routine visit. And the OBGYN says, listen, you better go get pregnant fast because you don't have an ovarian reserve left, panicking the patient. So, when the patient comes in, we always obviously interview the patient, but we always do an ultrasound, because an ultrasound, you take one look at that person's ovaries and they've got antral follicle counts of, 16, So, I'm exaggerating a little bit, but the AMH may not be, or may not correlate necessarily with what's being seen on the ultrasound, and depending what lab it goes to, it may not even be accurate. But in cases where it is accurate, where maybe the patient's 38, 39, 40, and they have a low AMH and their antral follicle count is low, I don't think it's a great idea to put them on birth control pills if possible, or if they go on them for a very short course, maybe for 2 weeks, maybe up to 21 days, no more than that. I mean, I wouldn't obviously program somebody's cycle for an IVF cycle in, November by putting them on birth control pills now. That's going to do them in. So one of the things I do a lot of is estrogen priming. And I think, we're seeing a lot in the literature about that too. That would be much more appropriate to do in somebody with a low ovarian reserve, and even for 2 or 3 months before they start, where that would help synchronize the follicle pool and, maybe bring more antral follicles up, just by synchronizing the pool a little bit, put those people on diminished ovarian reserve vitamins, acupuncture for 2 to 3 months, all that together. That would be a benefit.
Okay.
That would benefit the patient.
And so that's what I've seen as a more of a shift towards the estrogen priming instead of birth control and patients with diminished ovarian reserve.
Yeah, it works. It really works good. I mean, we've had a lot of success with that.
Nice. And do you see an increase in the follicles every month with? We
do. I'm just thinking of 2 or 3 patients now. I just started one the other day, and she was like in shock, because I remember when they first came in, she had very few, and I actually started her because she was anxious. We started her very quickly, and I had to cancel her, and because she went, she didn't stimulate, and then we went back to the drawing board and put them on for 3 months. Estrogen priming, and now she's got, I think, 7 in one ovary and 3 in the other. Now, hopefully the egg quality is good. I'm not saying that the egg quality is going to be so pristine now that every egg is going to fertilize. I'm not saying that, but now that we have more, it's obviously better to have more. You have a better chance of having a normal, embryo or two created out of a larger batch of eggs.
Have you had any pregnancies naturally?
Absolutely. So I had one 2 months ago, I think, where I was just priming her with estrogen. She gets pregnant. Boom.
That's what I was wondering. It's totally safe. And well, I mean, you're just basically getting, very cool. I mean, I think that you're not giving progesterone, correct? Just the estrogen, or
just estrogen. Okay. Well, sometimes there's a short priming protocol I use, which is usually just giving estrogens after ovulation till the menses. Or there's a long one where you can prime them the whole month with estrogen the whole month, plus progesterone, and even a low-dose testosterone. You give them a little bit of male hormone, a little androgen with it, because that'll sensitize their eggs to FSH and things and help recruit more eggs in addition. Because you need male hormone in the ovary, to help bring eggs up to the surface.
So I'm sure she was thrilled, the patient who was trying to help with, getting more follicles, and she got pregnant naturally. That's pretty cool.
Yeah. So it happens. I mean, it definitely happens. So, I mean, even sometimes occasionally a premature ovarian failure patient where we put on estrogens occasionally.
Oh, nice. Yeah. Very cool.
Yeah, so it shows you the benefits of estrogens,
Mm-hmm.
really, in sort of, resting the ovaries, allowing the ovary to regroup, allowing the eggs to, come back to the surface of the ovary, lowering the pituitary FSH. I mean, it really has a benefit.
And what's the highest FSH you've seen it work with? When you,
With a pregnancy?
well, in general, with response. So if you have someone with a very high FSH,
Well, I mean, we see people with premature ovarian failure who've got, FSHs, 125, 130,
mm-hmm.
Typically they're, and those patients have 50, 60, 70 FSHs, but that's a different problem really than what this person has.
Right.
This person probably just has a low ovarian reserve, but has a, an FSH, maybe a 15, 16. I don't know what our FSH is, but it's not going to be anywhere near somebody with ovarian failure.
With ovarian failure, are you able to get some follicles, you said, with the estrogen?
Rarely, yes, depending on how long they've had it. Yes, on occasion we do. I try a lot of those patients on estrogens for 3 to 6 months and follow their antral follicle counts and see if they have any resumption of that. You start to see antral follicles there, and if they don't withdraw bleed from progesterone, they may be pregnant, and that's happened.
Very cool. Yeah. And I'm interested because a lot of times when we're making Chinese herbs, they're actually phytoestrogenic, so they could be kind of working in that same level. Have had that happen where patients are preparing to do another IVF cycle, their FSH slightly elevated, so we do a few formulas that we use. They're traditional Chinese medicine formulas, and they get pregnant naturally sometimes. So
it may be the lowering of the FSH.
Right. The little. So I think it's definitely that's why we say, like, listen, don't ever let anybody tell you that you cannot get pregnant. I really think, and unless there's a structural thing going on or something, right. I just think there's a will, there's a way. And definitely with all the techniques that are out there, there's so many options. So just do not give up. If you go somewhere that is telling you that your FSH is too high, that you should just forget about it, or your AMH is totally crappy, get a second opinion. I think that's important because sometimes we do see patients that have been in really depressed because of AMH. But like you said, they go in and they see you guys and they have follicles, and they're able to do an IVF cycle. So it's like you're more than a number. So hopefully that can resonate with any of you that might have felt discouraged. There's definitely other options out there. So
right.
You've seen.
It's always good to get a second opinion on things.
Yes.
I mean, I think it helps.
The longer you see, the longer you practice, the more patients you see, the more you know that that there's really, I mean, to me, nothing is surprising because there are so many outcomes that we see that were looking like they were impossible, and it's possible. So definitely, there's hope. So as far as those were the questions that we had submitted. Please, you guys feel free to ask questions if you have any. We're here to help tonight. We'll also have Dr. Gelman here with us every month, like once a month. We're going to do this. Next time we'll try to also use the IVFMD Instagram also account, so we can make sure that everybody knows. Hopefully you guys have found us over here, but either way, we have actually one more question coming in. How long does it take for the immune test results to come in?
Usually about 2 to 3 weeks.
Yes.
Sometimes they get them faster, but usually it's around 2 to 3 weeks.
Very cool. Yeah, and in the meantime, if you're waiting, you don't recommend getting pregnant in that time. I mean, as far as if someone has miscarriages and they're not really sure where that's coming from.
That's always a tough call too, because patients again are very, very anxious, and they're worried, and they maybe they're a little older, they want to try and all that, and I guess we advise them not to until we get the test back. 2 to 3 weeks obviously is not a long time. So, I mean, we can get most of the workup. I mean, there's a pretty standard workup for miscarriages within the month, you know, so it might take us, you know, a month sort of get everything back, and then maybe discussing everything, what to do the next month, and then, you know, kind of get going again. So it might put on hold getting pregnant for maybe 2 months, which isn't horrible, but, you know, some patients don't really want to wait.
Yeah, and I remember we saw a patient who had 4 embryo transfers, and they were done at another center, but they were perfectly healthy embryos. And each time she unfortunately lost the pregnancies, or they didn't take. So in PGD, everything was normal in the embryos. So then she actually came to you guys. You did the testing, and she had high natural killer cells and then positive APA. And so she had to go on blood thinners, and she had to do, intralipids, and she was able to do her transfer, and she had a healthy baby and a healthy pregnancy. She just delivered recently. And, to her, like, it really, what is like a few weeks in the scheme of things? Like that made a difference between a healthy pregnancy or another loss. And I believe that was her last embryo as well, the last frozen one.
Yeah, I mean, we certainly like to, pat ourselves on the back and say, we found the problem. And, obviously, I think probably in that situation, we probably did, I mean, there's always still going to be questions about was it the embryos or not really? Were they really normal? Maybe this was the one that was really normal that implanted. We're always going to get those questions. But still, I think in situations where people are certainly in that patient would definitely need an immunologic evaluation, which, I think there are some centers that, wouldn't necessarily buy into that.
Right.
And again, we've been doing that for many years. And I firmly believe that the immune system plays a big role.
Definitely.
There's too much evidence over the years, I think, that and doing this too many times that we really think it does make a difference. So treating that patient was a good thing, obviously.
Definitely, yeah. He's so grateful. So how do you have a patient question from someone saying, how do you treat a patient that has a normal TSH level but extremely high antibody?
Yeah, that's a tough one. Those situations, that patient's going to be autoimmune. There's some studies that say that they have, maybe about a 15% risk of miscarriage because of the autoimmunity. I mean, I probably would check in that patient natural killer cell activity, phospholipid antibody panels, things like that, and then consider. Some people say that putting that patient on thyroid pills probably makes no difference. I probably put them on some thyroid pills, make sure that TSH was under 2.5, closer to 1, and probably treat them with dexamethasone, a little steroid to try to reduce any antibody production. And I've used selenium. 200 micrograms, I believe it is. And I've seen some results with that. I mean, it's very anecdotal. There's been some studies over the years that it reduces the antiphospholipid antibodies. The antithyroid antibodies. And I've seen it work.
It does help that function.
It can. I've not seen it work in everybody, but it certainly could be added. It's not harmful.
Very neat. Yeah. And would it be necessarily Hashimoto's thing if somebody...
Yeah, that's Hashimoto's thyroiditis.
Yeah.
Causing that.
So
but, there are a lot of women out there who have positive thyroid antibodies who don't have active thyroid disease. So if they go to their internist might do a whole panel, including a thyroid profile, TSH, TFT4, all that stuff's normal, and they have positive thyroid antibodies. They may not even mention it to the patient. But that patient probably has a family history, more than likely. Their mother has thyroid antibodies or thyroid disease, or their sister, or whatever it may be, because it usually always runs in families. And that patient, when they're in the pregnancy realm, they may or may not have any problem. I mean, there's patients out there who are on Synthroid for Hashimoto's thyroiditis and still have very high antibodies who do fine, So it doesn't mean for sure they're going to miscarry. I mean, there's maybe an increased incidence of it. I think there's a certain population where the thyroid antibodies are associated with a little more autoimmunity than others, possibly.
Okay. So definitely she should be on some treatment though. I mean, for sure. If she's,
Well, I probably would, especially if she's miscarried. I would be looking at that.
yeah. It's also easy to miss, right? Because if you're just checking TSH, like,
Right. Yeah, you should always do a TPO titer, thyroid peroxidase titer.
and we see it over and over again, just TSH. Like,
Yeah,
no.
well, that's what I'm saying. We'll pick that up,
Hmm.
and maybe a good smart OBGYN will pick it up too,
Yeah.
and some internists. But you're right. Most general doctors probably will do a TSH and no TPO for sure, unless the patient requested or tells them that, listen, I have a family history of thyroid disease.
Yeah.
They should do it.
Yeah, for sure. Well, definitely that's why you need to see a reproductive endocrinologist instead of,
Right. Yeah, because we're aware of that. And, it's done on our routine titer, our routine panels that we come in. So anybody that comes in new is going to get a routine panel, which will include thyroid antibodies and TSH, obviously. So, that's part of it.
it's very thorough. Yes. It's
Yeah.
great to have information
Yeah,
out.
you have to do that. I mean,
Yeah.
it's,
We have another question because we're getting down. Well, we actually have about 10 more minutes left too, guys. If so, please
well,
away. We're keep.
I see a little timer up there.
Yeah.
Is that,
We,
that's a 10? Yeah.
so there is a question regarding surrogacy process. I want to know if I can have twins or is that not possible? I believe if she does have a surrogate or if she is a surrogate, I'm not sure. If you can clarify that, but could they have twins with a surrogate?
We don't normally, do that. Normally, most places now are encouraging a single embryo transfer into people. So the complications, the insurances, a lot of people these days are, being really cautious about increasing complication and increasing costs and things like that. And we know, like with twin pregnancy, the costs can be astronomical with something like that because very often they're born premature. Premature infants are in the NICU, and you can imagine what that cost is. And, they all have, a lot of them have complications. I mean, and some of them can be really severe. Cerebral hemorrhages, and, lung problems, socialization issues, eye problems. We're trying to avoid all that and also obviously decrease the cost to the medical system, the medical care system. And insurance companies are really cracking down on it also. We want to be in good standing with all the insurance companies too, and, abide by what we think is very good care. And if the CDC comes out and says one at a time, that's what we're going to do, especially, a young woman, for the embryo at PGT and, is normal, you're getting a single embryo transfer. Obviously it can split. I mean, it's rare, but then that we'll deal with, but that's not what we're aiming for. We're not aiming for twins in people with rare exception these days.
Now the twin question comes up quite a bit. I know
Yeah.
that happens, but I agree. I mean,
well, it's understandable from the patient perspective. They want to have two and done. They all come in, I want to have two and done and that kind of thing. But, they don't quite, and we have to educate them with the ramifications of all that. And that's what we do. And then hopefully they understand all that. And, obviously they get pregnant with a singleton and it goes to term and it's healthy. That's what we want.
Yes. A healthy mom, healthy baby.
Yeah.
And we also have a question about what is fresh IVF retrieval direct to FET?
What is what?
It says the question is, what is fresh IVF retrieval direct to FET?
What is IVF direct to FET?
Well, I think they're maybe curious about, I'm trying to think, IVF retrieve. So basically retrieving, well, I mean, I guess what they're asking for is when do you retrieve eggs for an FET? I mean, that's generally done, prior to, and so maybe explain the process.
Well, I think they're asking about what is IVF direct, fresh IVF direct FET. I mean, that means we would not do a fresh transfer in the
Okay.
retrieval cycle.
Uh-huh.
We wouldn't be transferring an embryo into that person's uterus. We would, generate the embryos from the retrieval, freeze the embryos, and then prepare that person for a frozen embryo transfer, which typically most places now are doing almost exclusively because, the pregnancy rates are as high or better than with fresh transfers, which, several times you would think would work in a particular person and they don't. And then we go do a frozen transfer. It works beautifully. And we all think that's due to the fact that the endometrium is prepared in a more natural setting versus a stimulated cycle where the endometrium is subjected to a lot of, high elevations of hormones that it doesn't normally see, and it may be on the advanced side. So that when you transfer an embryo, it may not implant. And that's one of the theories that happens when a fresh transfer doesn't work. So a lot of places go to, frozen transfers, especially in the retrieval cycle. The progesterone may rise abnormally, affecting the implantation. And, there's factors we now know that could, affect the implantation in a fresh cycle. So a lot of times we do frozen cycles almost routinely. And again, we have a lot more control over those frozen cycles about, implantation. So it's a little more technical, takes longer. So, it's more of a process now, but it's worth it. The success rates are as good or better.
Very nice. And as far as if are you guys still doing virtual visits or
Yes, yes, absolutely.
Because we've had a few virtual visits ourselves, and when we talk to patients that are in different cities and sometimes different states, and we tell them about you guys, we tell them that you're still doing virtual visits and you're able to order labs and all of that, right? Just like you.
Oh, absolutely. I mean, there's no, we work with patients all over the world. I mean, easily, because everything can be done remotely now, which is great. I mean, it's really terrific, but, it's nice to have the patient there in front of you. I mean, to do an ultrasound and sort of get to know them a little better and to know and to have everything in person. But where it's not possible, we can definitely work remotely. It's not out of the realm of impossibilities, and we do it quite frequently.
Definitely. And I know that, things change all the time with this virus. So hopefully we'll all be through this very soon. We're all taking the precautions that we are doing in our office as far as screening.
Like I said last time, I'm glad I'm not wearing a mask. I mean, it's just
Morning you were geared up, for surgery.
I know. Listen, I'm taking this very seriously. I don't take any chances with this.
Right.
It's too serious a problem, and you never know how it's going to react.
Yeah.
God forbid you get exposed, and it's not a good thing. You get, your family, all that. I mean, God, I don't wish that on anybody.
Yeah, definitely. And we've been, asking our patients as well, obviously, to notify us. I think, as patients have more testing done and we learn more about this, we're still finding out things about pregnancy, about how does it affect pregnancy and that sort of thing. Well, and there's a lot of unknowns with it too. So all we can do is support our immune system and stay healthy and try to get good sleep. We just posted a TED Talk on sleep that actually showed that if you lacked like 4 hours of sleep, I think that they did a test where the subjects actually didn't sleep for 4 hours. And their immune system went down by 70%.
Yeah, I believe that. Oh, I believe that.
A huge thing. So I think number one thing that we would recommend above any supplement or anything is sleep. At least sleep, 8 or 9 hours a night if you can. And we are constantly asking our patients, like, how's your sleep? What can we do to improve your sleep? Because we can improve hormones as well through sleep. Many things happen during that time. So hopefully that's something that everybody's trying to do better about. And it's a huge factor in your immune system. So I know this is not about the immune system tonight, but I think it all ties in as well to reproductive health and all of that.
Absolutely, everything. Absolutely.
And I also mentioned this morning, we were talking about cortisol, I think in our last Q&A. and how to measure that. And we do measure cortisol in urine. There's actually a test out there that you can measure that at home on urine strips, test strips. And lately we've been seeing that the cortisol levels we're expecting to see a really high cortisol lately. They've some of the patients have realized, like, okay, now that I'm at home, I'm realizing that I'm totally burnt out because they have been going for years and years and years, and now this has been the opportunity to actually just kind of reassess and really put things in perspective. And when we looked at their cortisol levels, it's very interesting, but a lot of them have been extremely low. So it's almost like they're like, gosh, I don't understand. I'm so tired all the time. I don't know what's going on. So this is the Dutch test is what it's called, the CAR, which is the cortisol awakening response. So we can actually we measure it in saliva and urine. It's really interesting. It's interesting for us too to kind of know what we're working with prior to someone getting pregnant. If they're already feeling really drained and no libido, then that's also not very conducive to getting pregnant as well. They don't feel like they want to really do anything in general. So we really work on that, like helping them recover as far as energy, their adrenals, all those things. So there's ways you can measure cortisol, but it's been very interesting to see this lately, where we've had many people stop traveling for work. They're not commuting as much, and they thought, oh wow, I'm going to have so much energy, I'll be rebounding, and they're just drained. So so there's ways you can actually support your body, your energy, and in many respects, acupuncture is helpful for that. Sleep, number one. So we try to go to sleep before 10 o'clock. Take all the lights out of your room, like anything through your windows. Take your electronics out of your room, the TV, all of it. And just see, and I'm really bad about checking my phone before I go to bed. I'll like look at the news app, which is horrible. It's like the worst thing to do, but like, okay, maybe something's happened.
Maybe people should read a book.
Yeah, reading a book is so,
it's kind of very relaxing.
yes, do something like that to kind of unwind your brain a little bit, so that you can sleep better. So so that's something that I just wanted to mention. We have those test kits available to check, because cortisol in blood is kind of difficult. It's hard to measure the diurnal patterns with just one reading. So this actually is right when you wake up and also throughout the day and before you go to bed. So it's pretty cool. Usually you still see a nice curve, and sometimes it's scary when you just see a flat line. You're like, okay, something's got to change with our lifestyle. So that's what we do. So we only have a couple minutes left. I want to thank you guys who submitted your questions. And also, if you didn't get a chance, you can do that next week as well. And then next month, we'll be back on Instagram as well with Dr. Gelman.
Right.
We're going to try to do this on a regular basis because I think it's really important to hear from you guys, and also to be able to answer any of your questions. So you can find Dr. Gelman on IVFMD.com, and then
thank you so much.
You can request a virtual visit there. You can find us on Florida Complete Wellness, and we will be happy to answer any questions you have. Please message them or us, and we'd love to help you guys any way we can. Any parting words of advice?
No, I think those were great. It was a great parting words there. In terms of sleep, I think that's one thing we never really covered.
Right.
As part of health, we talk about nutrition. We talk about, obviously exercise too. Exercise is a good way to help, sleep better. Make sure you get some kind of physical exercise, maybe a nice long walk. When you get home from work or something like that, and even for 30, 40 minutes. A swim, something to relax you and get the stress out of your body. You'll sleep better at night. Awesome. So I think sleep is very neglected in our conversations. I think that was very important.
Well, thank you guys so much for joining us. Have a good night.
Thanks again,
everybody, and we hope to see you soon.
Everybody stay safe.
Take care. Thank you, Dr.
Bye-bye.